Hello all and welcome to this EMJ live webinar, Genomic Profiling of Breast Cancer, Supporting Multidisciplinary Treatment Decisions in Early Stage Breast Cancer. My name is Dr. Julianne Locke, your host for today, and I'm delighted you have joined us for what promises to be a fascinating webinar. In today's webinar, we are joined by two esteemed experts, Dr. William Audeh, he's the Chief Medical Officer with Agendia, and Dr. Cathy Graham from the Emory School of Medicine. We will hear about the latest data supporting the utility of MammaPrint and BluePrint assays from Agendia for early-stage breast cancer patients and hear about their real-world impacts. Additionally, we will also discuss through a case-based review how genomic profiling may be useful when planning pre- and post-operative breast cancer treatment. Dr. William Audeh is currently the Chief Medical Officer with Agendia, and he has been a medical oncologist for over 30 years, specialising in breast cancer, and prior to joining Agendia, he served as the Director of the Cedars-Sinai Cancer Centre in Los Angeles. Dr. Cathy Graham is an Assistant Professor of Surgery in the Division of Surgical Oncology at Emory University School of Medicine and is Director of Breast Surgery at Emory St. Joseph's Hospital in Atlanta, Georgia. Her main clinical interests include benign and malignant breast disease, breast cancer risk and risk modification, as well as personalisation of treatment. So after the presentations, there will be a question and answer session. So please do place any questions you have in the question box at the bottom of your screen, and I shall endeavour to get through as many of these as possible. If we don't have time for everything, we will hopefully be able to contact you with an answer at a later date. This webinar is sponsored by Agendia. So first up, Dr. Audeh in his presentation will talk us through some of the latest data on the potential for gene expression signatures to inform breast cancer management, including the imprint immune signature presented at the ASCO conference, and update us on neoadjuvant breast symphony trial or NBRS was shown to predict treatment response and long-term outcomes. We will then head into a discussion with Dr. Graham, where they will both discuss a variety of case studies. Dr. Audeh, over to you.
Well, thank you very much, Julianne, and thanks to the organizers to allow us to present not only some of our newest data, but also an in-depth case review with my colleague, Dr. Graham. To begin, I want to remind you of the assays that are provided by Agendia for evaluation of early stage breast cancer. You can see them here, the MammaPrint 70 gene assay, which identifies the potential for distant metastasis in a newly diagnosed breast cancer. And on the right, the 80 gene BluePrint assay, which identifies the signaling pathways based on gene expression, driving cancer growth, and will stratify tumors as being either luminal type or hormonally driven, HER2 type or driven through the HER2 receptor signaling, or neither as the basal type. It's also important to point out that these assays may be performed on any formalin fixed paraffin embedded tissue sample, including either the formal surgical resection or now most often on core needle biopsy, because the amount of tissue that we obtain is clearly enough for us to obtain the requisite mRNA. In recent years, we've expanded the diversity of stratification with these assays. And so now in MammaPrint, within the low risk category, we identify both an ultra low risk and a low risk with different clinical implications. And in the high risk category, a similar identification of high risk 1 and high risk 2, each of which also have different clinical management implications. On the same tumor tissue and at the same time, we can assess all 150 genes in this comprehensive assay. And the result is a comprehensive stratification of different clinically relevant subtypes. Most importantly for our discussion today is the fact that these assays through functional genomic profiling identify 5 distinct subtypes of estrogen receptor positive breast cancer shown here, and we will discuss several of these in the case discussion. I'd also like to point out some recent publications regarding data using MammaPrint and BluePrint. Here earlier this year, we had data from the MIND-ACT trial in which we specifically looked at that ultra low risk category in MammaPrint, which I just mentioned. Out of this study, which enrolled nearly 7,000 women, 1,000 of them had a MammaPrint risk, which was in the ultra low category. And we define that by the MammaPrint index as being in the positive range above 0.355. The implications of this ultra low category are described in this paper, but shown here are one of the data slides which indicate the extraordinarily good long-term outcome of these individuals here by 8-year distant metastasis-free interval, regardless of therapy. As you can see, the three arms of therapy, endocrine therapy for the most part, but also a group that received no adjuvant systemic therapy. All of these groups do extraordinarily well. And that leads us to the conclusion that although these ultra low risk patients have an excellent prognosis, they certainly should all be advised to take anti-estrogen therapy, but the clinical utility may be that clearly for postmenopausal women, if they're having significant toxicity, they may be able to safely discontinue therapy and still have an excellent outcome. Two additional publications which I'd like to mention are regarding the so-called NBreast trial, which was a neoadjuvant study in which patients receiving a neoadjuvant chemotherapy had both MammaPrint and BluePrint performed in addition to their standard pathology. And the rates of pathologic complete response as well as 5-year outcomes were assessed. In this particular paper recently published in the Annals of Surgical Oncology, we looked at the effect of age on the likelihood of response to chemotherapy, because as everyone in the breast cancer field is aware, there is currently a controversy as to whether there is some intrinsic chemosensitivity in breast cancer in premenopausal women versus postmenopausal women. So in this study published recently, we showed that within the MammaPrint risk categories, there is actually no difference in the rate of pathologic complete response due to age. In other words, a low risk MammaPrint or a high risk MammaPrint predicts the likelihood of a pathologic complete response, but those rates are not different due to age. Going on to BluePrint subtyping, we see a similar story in which when the BluePrint subtype is held constant, age has no effect on the likelihood of a pathologic complete response. In the discussion that has occurred regarding whether or not chemotherapy is inducing secondary ovarian suppression, here we see that the response to neoadjuvant therapy is equivalent between younger women and older women. And therefore, this is removing that possible effect of later secondary ovarian suppression. A second paper published in the Journal of Clinical Oncology, Precision Oncology, described here, looks in depth at a group of patients that are identified by BluePrint as being estrogen receptor positive by immunohistochemistry, but basal by genomic gene expression profiling. In other words, although there is estrogen receptor present, there appears to be no signaling through that estrogen receptor, and these tumors behave essentially like triple negative breast cancers. In this study, we found that the proportion of estrogen receptor positive patients that are genomically basal is approximately 15%, but in higher risk populations, the proportion may be as high as 29%. There is no evidence of estrogen receptor signaling, despite the presence of immunohistochemical positive estrogen receptor up to 99%. There are no specific pathologic characteristics that clearly identify these cases. They have a high chemosensitivity rate, similar to triple negative, and also similar to triple negative, a very poor outcome if they do not achieve a PCR, unlike other estrogen receptor positive breast cancers. Lastly, and most recently, are the data presented at ASCO just a few weeks ago in collaboration between Agendia and the I-SPY study conducted out of the University of California, San Francisco, in which a new signature was described known as imprint. This is an immune response signature, which was derived from looking at those individuals in the I-SPY trial who achieved a pathologic complete response to immune checkpoint inhibitors. This essentially provides a new biomarker for identifying those individuals who may benefit, at least in the neoadjuvant setting, from immune checkpoint inhibitors. And the important aspect of these data that was presented is shown here, in that of the proportion of women who are estrogen receptor positive and HER2 negative who are enrolled in this trial, all of whom are MammaPrint high risk, 25% had a positive immune response signature, predicting that this is a hormone positive population that may clearly benefit from immunotherapy, similar to what we are now seeing, of course, in triple negative breast cancer. And this represents, of course, a unique and large population of women who may also benefit. The I-SPY trial integrates MammaPrint and BluePrint for therapy allocation, and now these other signatures are also being integrated. So with that, I will now turn things over to my esteemed colleague, Dr. Graham from Emory, to discuss her cases.
Great, thanks so much, Bill. It's really nice to be here, and I appreciate you guys providing us this platform in which to speak. I'm gonna kind of run through these cases fairly quickly, but I do have some questions about them based on your presentation of the recent data. So we'll go through the cases and then we'll have some discussion of my questions, and hopefully that will generate some questions in our audience. My first patient, JH, is a 46-year-old premenopausal patient who went for her first screening mammogram without complaint. And in the initial screening, she was noted to have issues of concern in each breast. She underwent diagnostic imaging and was ultimately identified as having a 1.9 centimeter solid mass in the right breast and an area measuring about 7.5 centimeters of architectural distortion with associated pleomorphic calcifications in the lower aspect of the left breast. And a biopsy of both areas was recommended. Now, on clinical exam, she did in fact have a diffuse sort of thickened area in the lower left breast, which correlated with that architectural distortion, but there was no discrete mass there. There was a discrete mass in the right breast, a 2 centimeter mobile, benign appearing lesion that correlated with the lesion seen on mammogram and ultrasound. She underwent ultrasound guided biopsy of the right breast mass, and there was an area in that 7.5 centimeter area of architectural distortion that measured about 9 millimeters that was identified on ultrasound. So they elected to biopsy that by ultrasound as well. So pathology of the right breast actually came back as a benign fibroadenoma, which is what we anticipated. But in the left breast, that architectural distortion showed an invasive ductal cancer, which they graded as grade 2 on the core needle biopsy. And there was associated ductal carcinoma in situ. Estrogen receptor was 98%, progesterone receptor 94%, HER2 was 1+ by IHC, and her Ki-67 was 28%, which is mildly elevated. We got an MRI for extensive disease in that left breast, and that showed an 8 centimeter area of poorly defined non-mass enhancement in that left breast, which extended close to the nipple. And the biopsy clip was about 1 centimeter from the nipple, but there was some concern about calcifications within the nipple. There were no other areas of abnormality noted in the right breast at the site of the benign biopsy. And there were no suspicious axillary or internal mammary lymph nodes on MRI or on ultrasound. So we got, as we always do, MammaPrint and BluePrint to help guide our treatment decision making. And this tumor in the left breast came back as a luminal, low-risk MammaPrint tumor. And if you look at that index, it is greater than the 0.355 cutoff for ultra low. So we consider this an ultra low risk ER positive tumor. Because she's ultra low risk luminal A, MammaPrint and BluePrint, we didn't feel that neoadjuvant chemotherapy was going to provide any significant benefit. She elected to undergo mastectomy based on the extent of disease seen on MRI and mammogram. So she had a mastectomy without nipple preservation because of the question of involvement of the nipple. And she had a sentinel lymph node biopsy. Now, in my practice, I am able to do frozen sections on my sentinel lymph node biopsies when I'm doing a mastectomy. So we did do that. On her final pathology, she had a 2.6 centimeter grade 3 invasive ductal cancer in that left breast with a significant amount of associated DCIS. But intraoperatively, when I got my sentinel lymph node biopsy, my pathologist called me and said, I think there's a 1.2 millimeter metastasis in this lymph node. Now, I have really good pathology, and I realize that doesn't always happen, but she really was convinced. And so I did a limited axillary dissection to avoid having to go back to the operating room. And ultimately, that final pathology showed only the one sentinel lymph node with a micrometastasis. So she was a pathologic T2 N1 MIC with extensive DCIS. She did meet with the medical oncologist, and of course, we had a multidisciplinary tumor board discussion, and we shared decision making. The patient elected to take tamoxifen, and she was tolerating that quite well. Oops, you went backwards, Bill.
Yeah, I'm trying to get it to advance.
So this is the data from MindAct that was initially presented in 2016. It talked about these low risk patients and how they have a very good outcome, even if they are in the node positive group. And of course, this was updated in 2020 with the 8-year survival. And as you can see, these patients do extremely well without chemotherapy. And this is the ultra low group that we talked about and that this patient was part of. And you can see that this good outcome is regardless of age.
Yeah, I'd like to just add in these data from MindAct that were just published in the Journal of Clinical Oncology earlier this year. Also did stratify these ultra-low patients by age, and as you point out, the outcomes are excellent for both those 50 and younger or over 50. The majority of these patients were treated with endocrine therapy alone, as we showed earlier, and so to some extent the controversy regarding the utility of genomic profiling in younger women is answered, I think, to some extent by these ultra-low data, in that we are able to find a group of younger women whose prognosis is so good based on MammaPrint that it is doubtful, of course, that chemotherapy would have added anything further. So you mentioned shared decision making, Dr. Graham, and that is very much what we believe the MammaPrint data from MindAct, which was level 1 evidence, supports, certainly for pre-menopausal women. This patient of yours falls into this category of clinical high risk with a T2 tumor and a micrometastasis in the node. And based upon the fact that she is not only MammaPrint low, but ultra low, I think it's clearly appropriate, as you described, that in shared decision making, a discussion of risks and benefits of either chemotherapy or endocrine therapy with tamoxifen and or with ovarian function suppression would be quite reasonable for this patient.
Great. So these are some of the questions, and you've answered some of them. My question is, does it make a difference if this is invasive ductal versus invasive lobular?
That is a good question. We do have data, actually, again, from the MINDAC trial with nearly 500 of those women having invasive lobular breast cancer by pathology. And their outcomes, based on the MammaPrint high or low risk, are the same as those for ductal cancer. In other words, an invasive lobular breast cancer that is MammaPrint low risk has the same outcome as an invasive ductal cancer. So it is really the genomic risk assessment that determines the outcome. One difference, however, is that the frequency of high risk MammaPrint is lower in invasive lobular cancers. But once you have a high risk or low risk, the outcomes are the same.
Great. Well, what if she actually had more nodal disease, say maybe 3 out of the 8 lymph nodes had either micrometastatic or macrometastatic disease? Does this ultra low thing still hold up?
Well, that's an important question. I think it's difficult to answer because in the MINDAC trial, the majority of patients with positive nodes had 1 or 2 nodes. The proportion that had 3 nodes was approximately 11%. So the data are less extensive for 3 positive nodes. And so I think with increasing clinical risk, while one could still argue that chemotherapy is still not clearly beneficial, the addition of ovarian function suppression, for example, may be considered because that adds to, of course, the effectiveness of the tamoxifen.
Okay, well, so then that raises the question about what about neoadjuvant endocrine therapy? Does this data tell us anything about its ability to get us to, say, breast conservation in this lady who had extensive disease?
Another excellent question. We do have data, as we will get to a bit later, on extended endocrine therapy in postmenopausal women from the NSABP B42 trial. But for premenopausal women, such as your patient here, the only extended endocrine therapy data that are available are from trials such as ADAM and ATLAS, where there did appear to be a benefit. But as of now, there really are no good biomarkers for identifying who may benefit from extended endocrine therapy in the premenopausal group, at least with robust high-level evidence.
Okay, great. And you answered my question with regard to extended endocrine therapy. So let's move on to the next case. JB is a 68-year-old Caucasian female, and she has a history of having a large inclusion cyst in her left breast, which I excised about 5 years ago, and she was returned to routine follow-up. But she noted a mass in her left breast about 6 months ago, and she thought it might be the same thing, so she kind of watched it for a while, but it was getting bigger, and so she came back to the office for further evaluation. And on clinical exam, she did in fact have a 4.5 centimeter firm mass in the lateral left breast away from her excision site, and actually had palpable adenopathy with at least 2 abnormal lymph nodes on clinical exam. So we sent her for formal breast imaging, and mammogram and ultrasound showed a highly suspicious 4.8 centimeter mass in the breast with at least 2 abnormal appearing axillary lymph nodes on ultrasound. Go forward, yes. So we did a core biopsy of the breast and an FNA of one of the abnormal appearing axillary lymph nodes. And we did put a clip in that lymph node. And we sent her for an MRI for extensive disease. And she was noted to have not only the 4.8 centimeter mass, but another 1.2 centimeter satellite mass, which was very close to the index mass. And a second look ultrasound and biopsy of that lesion was recommended. We did do some genetic testing on her because she had a strong family history of breast cancer, both in her mother and her sister. She was not found to have a deleterious germline mutation, but she did have a VUS in PALB2, which is kind of interesting. They did not commit, this is pathologic or non-pathologic. They just didn't have enough data to describe it. So let's go to the next slide. So on her pathology, this 4.8 centimeter mass in the left breast was in fact a grade 3 invasive ductal cancer. Estrogen was reported out at 42%, progesterone receptor 2%, HER2 was 1+ by IHC, but her Ki-67 was really high at 76%. And that little satellite lesion that was within a centimeter of the primary lesion had similar characteristics. The lymph node FNA showed malignant cells which were consistent with metastatic breast primary. So let's go to the next slide. So our genomics, which again we do pre-treatment, was a little surprising to me. I mean, she's ER positive by 42%. She came back high risk, and if you look at that index, that's a very high risk index. But her molecular subtyping by BluePrint showed a basal type tumor, which was a little surprising to me given that she is estrogen positive. So let's talk about this. This is the summary of the case. She's got a clinically high-risk tumor. It's 4.8 centimeters with a satellite lesion. She's grade 3. She's node positive. So in this case, there's little doubt that we would recommend neoadjuvant chemotherapy. And so that was in fact recommended for her. She got dose-dense Adriamycin cytoxan followed by weekly paclitaxel. And she had an excellent clinical response. I could not feel the mass in the breast anymore. I certainly could not feel the lymph nodes in the axilla. And we did post-treatment imaging, which supported her decision to have an attempt at lumpectomy with sentinel lymph node biopsy. So we did that, and on her specimen X-ray, we had both of the biopsy clips from the breast in the specimen, and we were able to obtain the previously clipped and positive lymph node with our sentinel lymph node biopsy. And of course, we did a frozen section on that lymph node, and it was interesting that the pathologist said, I see a lot of treatment effect, but I see absolutely no viable tumor in any of the sentinel lymph nodes. So we did not axillary dissect her. My question on this case is, for these patients who come back as basal on their BluePrint, but they are estrogen receptor positive, does it matter how strongly positive they are? I mean, this patient was 42%, and I kind of suspected that it wasn't going to be the typical ER positive breast cancer, but do you see basal tumors that have stronger ER expression?
Yes, actually, that I think is one of the most interesting features of the study that I mentioned earlier that was recently published, looking at the biology and the clinical behavior of these ER positive basal breast cancers. These are data that have been presented previously which look at the topic you just raised, which is the percentage of ER positivity by immunohistochemistry in these ER positive basal breast cancers. And although many assume when they hear this category of ER positive genomically basal breast cancer identified by BluePrint, people assume that these are the very low ER expressors, less than 9% or less. You can see that the range of ER expression is actually quite huge. In fact, although there is a clustering in the lower range, you can see that estrogen receptor can be as high as 99% positive and still show no evidence of signaling by gene expression. Progesterone receptor is a bit more informative in that we rarely see it above 50% positivity in these ER positive basals, but the presence of estrogen receptor at almost any level is possible in these ER positive basal breast cancers. Their behavior, of course, is very similar to triple negatives as shown here. And I think one of the commonly asked questions is it really necessary to treat these patients any differently because they appear to be more biologically similar to triple negative than to luminal tumors? So shown here again, data from the recent publications are the outcomes at 5 years for those estrogen receptor positive BluePrint basal tumors, stratified by whether or not they achieved a pathologic complete response. And you can see the PCR group in green and the no PCR group in red on the left, with a significant difference in their 5-year probability of distant metastasis-free survival, a curve that is almost identical to what you would see in triple negative neoadjuvant therapy. Regarding the question of whether these should be treated differently or not, you see on the right the two groups of high-risk ER-positive patients that we are able to identify further with BluePrint stratification. So in blue are high-risk luminal tumors, which are labeled as luminal B, versus the high-risk basal tumors, ER-positive basals. You can see the PCR group in the solid line, the no PCR in the dotted line, and I think that the most obvious difference is how very differently they do over time, whether they're luminal B or basal. There's clearly a much worse outcome for the ER-positive basal tumors that don't achieve a PCR, arguing that they should probably receive the most aggressive chemotherapy regimen that makes sense these days, more of a triple negative type regimen, perhaps as this patient received with dose-dense ACT.
Bill, that kind of raises the question of, should we think about these ER-positive basal tumors more like triple negatives? And if they do have residual disease after neoadjuvant chemotherapy, should we be considering additional adjuvant treatment?
Yes, that's an excellent question that we're absolutely pursuing because we were not able, of course, to ask that particular question in the NBreast trial. But as you can see, with such a poor outcome for those not achieving a PCR, similar to triple negative, we certainly are asking naturally, would capecitabine adjuvant therapy, as is now the standard of care in triple negative, be appropriate for these patients as well? We are pursuing that answer with interest in the CREATE-X trial, of course. And this also raises the question as to whether these ER-positive basal tumors should, as triple negative breast cancers now are, should be considered for immunotherapy up front. And we hope to learn much more about that as we have more use of the imprint signature as well.
Great.
I think a further question, Cathy, is, which I'm often asked, is given that these appear to have no signaling through the estrogen receptor pathway by gene expression, Do they really need anti-estrogen therapy?
Right, yes, should we be?
Another excellent question for which we don't have an answer, that the standard of care remains 5 years of anti-estrogen therapy.
Okay.
Although one could question how valuable that is for these patients, I think as of now, the standard should be to maintain that treatment. Although I would say that the threshold for stopping early due to toxicity may indeed be lower, given the question as to how effective it is for these women.
Okay, great. Okay, let's move on to case number 3. This is actually kind of an interesting case in that, you know, we talk about these patients at Tumor Board every week. This is a 51-year-old perimenopausal lady who noted a palpable mass in the upper inner quadrant of her left breast in early 2020. And of course, we know that that was the height of the COVID nightmare. And she did not make it in for medical attention until mid to late August of 2020. We were able to get mammogram and ultrasound, and this demonstrated the presence of a 2.2 centimeter high density mass in the upper inner quadrant of the left breast. The lymph nodes appeared normal on axillary ultrasound and were clinically non-palpable. So she underwent core needle biopsy of this breast lesion. And the pathology demonstrated a grade 1 to 2 invasive ductal cancer. ER was 97%, PR was 34%, HER2 was 0 negative by IHC, and her Ki-67 was quite low at 6%. Again, MRI for extensive disease showed a mass in the right breast. Recall this tumor's in the left breast. And she underwent a biopsy of that. It demonstrated a fibroadenoma, but there was some atypia on core needle biopsy. So we, again, sent the invasive cancer for genomic testing. We got a MammaPrint and a BluePrint. And interestingly, she's a luminal A, low risk MammaPrint, but again, hits that cutoff for the ultra low risk. So she was greater than 0.355 positive. And so she was ultra low risk. Go to the next slide, yeah. So she actually elected to do bilateral nipple sparing mastectomies after a long conversation. And so we did that with a sentinel lymph node biopsy on the left. Now the standard of care for a 2.2 centimeter ER positive, HER2 negative, node negative invasive breast cancer with low risk genomics would be endocrine therapy alone. And since she had bilateral mastectomies, of course, no radiation was recommended. She was started on tamoxifen, and she had excellent tolerance. And after starting on tamoxifen, she went another 13 months without a period. And we were kind of thinking about switching her over to an AI. But then she developed really heavy vaginal bleeding and had to go in for a workup. And the ultrasound on the pelvic ultrasound showed that she had some endometrial thickening. And with her history of tamoxifen therapy, they strongly recommended, you know, a biopsy of this area. Fortunately, this proved to be a benign endometrial polyp. But we were then thinking about what are we going to do with this lady's endocrine therapy? So I'm just going to tell you that we went back and looked at her MammaPrint again. And at that point, it kind of hit me, oh, this lady is ultra low risk. And she's already had 13 months of therapy, and she really has a significant complication associated with her endocrine therapy. Does it make sense for us to potentially de-escalate that therapy for this patient? And of course, this is the data that you know I used to have that discussion with her. So these patients have an excellent outcome. And if you look at that x-axis, that's 20 years of follow-up. So we had a conversation about potentially de-escalating her endocrine therapy, which she was delighted to do.
Yeah, this is an excellent example, Cathy, of where the knowledge of the ultra low risk category can be helpful in a woman who started on standard of care therapy but encountered a problem with her anti-estrogen therapy. These data shown here are from the initial publication regarding the clinical meaning of the ultra low risk MammaPrint category, published by Dr. Laura Esserman from UC San Francisco in collaboration with colleagues in Stockholm. These were data from one of the original Stockholm tamoxifen trials conducted in the late 1970s and early 1980s, which is why there were 20 years of follow-up data available. This was a trial done at a time when the question was still being asked whether adjuvant therapy was even necessary for postmenopausal women with clinically low risk hormone-positive breast cancer. So this particular study had over 650 postmenopausal women, node negative, tumors up to 3 centimeters in size, all very similar to your patient, who were then, who were then randomized to receive either no therapy at all, shown in the dotted green line, or some amount of anti-estrogen therapy in this solid green line. The majority of these patients who were treated with anything received only 2 years of tamoxifen, which was the only agent available at the time. Proportion went on to receive a full 5 years, but as you pointed out, you can see either group does extraordinarily well. At 10 years, both groups had nearly a 100% breast cancer specific survival. And out to 20 years, 94% for the group receiving nothing, and 97% for the group that stopped at 2 years or continued for 5. So while this group was defined as postmenopausal, it's hard to imagine that let's say a perimenopausal woman would have a very different outcome or pathology. So given that your patient has developed problems with tamoxifen, one could either consider determining whether she's appropriate for an aromatase inhibitor at this point, or simply allow her to stop given that her risk is so extremely low.
Great.
I wanted to add, as we were discussing this case, the data shown earlier, which is that from MIND-ACT, a more recent cohort, of course, the ultra low risk group showed the same kind of high rate of breast cancer specific survival, regardless of clinical risk, out to 8 years, confirming what we originally reported in that SDO data.
So these are kind of the questions that I had with regard to this. Obviously, you answered the question about the pre and perimenopausal patient. Should we still continue to give these ultra low risk patients endocrine therapy and then de-escalate based on their inability to tolerate or complications? Or should we consider giving them a shorter course or even maybe omitting the endocrine therapy based on shared decision making? And this is kind of what we did with her. And I think, the data that you presented really suggests that that's the value of knowing the ultra low risk category. Now, my question to you is, are there patients who actually have node positive disease who have an ultra low risk genomics? And I think I can answer that question because our first patient actually had a micrometastasis and had an ultra low risk genomics. But can we use this information to think about de-escalating in a different way? I'm a surgeon, and so we're always thinking about, are the surgeries we're doing really valuable for helping patients avoid recurrence or persistent disease? And my question is, do you think we could maybe use this information to de-escalate axillary surgery, given that these patients really have an outstanding, long-term survival, cancer-free survival?
Mm-hmm. Well, again, as usual, Cathy, you always pose the most interesting and important questions. I want to address the first part of your question, because I think it's very important. It's something I'm asked quite often regarding these ultra-low data. I do not think that even with this ultra-low risk MammaPrint category, that endocrine therapy should be withheld from the outset. Clearly, endocrine therapy is the standard of care, and it remains the standard of care even with these data to begin the standard 5 years of endocrine therapy. I think the main utility of knowing that a woman has an ultra low risk tumor by MammaPrint is if she were to encounter significant toxicities that may either be of some danger, such as endometrial bleeding in the case of tamoxifen, or simply the quality of life issues that arise with aromatase inhibitors, certainly, arthralgias, memory loss, hot flashes, all of those other things that can really affect some women so severely that they want to stop before the full 5 years have been completed. And I think knowing that a woman is ultra low, the data are quite robust that it does appear safe to stop short of a full 5 years and still expect an excellent outcome, at least for postmenopausal women. The data are certainly less extensive for truly premenopausal women. Regarding your second question about de-escalating aspects of care, in this case, a node positive patient, did they really need an axillary dissection? There are actually a number of trials ongoing that are using low-risk genomics, including MammaPrint ultra-low risk, to ask those questions. There are trials soon to be started, actually, both in Europe and in the US, looking at a shortened course of endocrine therapy for ultra-low risk patients, de-escalating the endocrine therapy. Other trials are looking at omitting radiation therapy in those women who've undergone breast conserving surgery. At this point, I'm not aware of trials that are asking the question about omitting sampling the axilla, but it certainly seems a logical question to be asking when you identify such a low risk biology.
Great. Okay, thank you. Okay, on to our last case. I just want to check our time to make sure we're doing okay. Looks good. AD is a 63-year-old postmenopausal female. She has a history of a left breast papilloma, which was excised after biopsy. She presented initially with spontaneous nipple discharge in 2017. The excision showed no atypia, and she was released to routine follow-up. However, in December of 2020, she had a screening mammogram that showed an asymmetric density in that same breast away from her excision site. And on diagnostic imaging, she was noted to have a 2.5 centimeter irregular mass at the 6 o'clock position, and at least 3 other sub-centimeter masses in that left breast, as well as 1 in the right breast. Her lymph nodes were non-palpable and appeared normal on both sides by ultrasound. She ended up having multiple biopsies, 1 in the right and 4 in the left. And the 2.5 centimeter mass that really was my biggest issue of concern proved to be an invasive ductal cancer. And one of the other lesions in the left breast, away from the invasive cancer, was a DCIS. The other lesions, including the right breast, were all papillomata. So on pathology, this 2.5 centimeter lesion in the left breast at the 6 o'clock position was a grade 3 invasive ductal cancer. ER was 97%, PR was 0, HER2 was 2+, equivocal by IHC, so we sent it for FISH and it was negative. But her Ki-67 was again really high at 75%. The other area in the left breast that was of concern was DCIS at the 3 o'clock position. It was grade 2, it was ER positive, PR very low %. And the other lesions in the left breast were papillomata, and the lesion in the right breast was similarly a benign papilloma. So again, we sent a MammaPrint BluePrint pre-treatment to kind of understand the biology of the disease. And this area in the 6 o'clock position at the left breast, which was an invasive ductal cancer, showed a high-risk luminal B tumor. So if you look at this information, there's only about a 6% chance of a pathologic complete response in women with a luminal B tumor. But we did kind of talk about it with the patient. And we were engaged in the I-SPY 2 trial. So you can go to the next slide. And we talked to her about that because she had a high-risk tumor that met the criteria for inclusion in the I-SPY 2. She was really interested in that. But at the time, that would require her to go to the main campus, which is right downtown Atlanta. And she was not really comfortable with that. So we sent her to the medical oncologist and they offered her 2 options. One was upfront surgery, which we didn't have any problem with, but they also offered her, 4 cycles of neoadjuvant TC. And she was really interested in having bilateral mastectomies based on these papillomata that had caused her so much trouble. But she was also really interested to know how her tumor would respond to treatment because we'd had this whole conversation about the I-SPY trial. So she actually elected to proceed with neoadjuvant TC just to see what kind of a response she would get. But her ultimate plan was to have bilateral mastectomies. So she had her 4 cycles of TC. She had an excellent clinical response. And we took her to surgery, and on her surgical pathology, she actually had a tiny area of residual microscopic DCIS at the 3 o'clock lesion, which was where she had the second lesion that was biopsied that showed DCIS. She had no residual disease at the site of, at the 6 o'clock position, which is where she had her invasive cancer. And all the other sites that were biopsied were indeed benign papilloma. And we did do a sentinel lymph node biopsy with frozen section. 0 of 3 of the sentinel nodes were involved. So here's my questions to you with regard to this patient. She had a luminal B high-risk tumor, and the pathologic complete response rate is only predicted to be about 6%, but clearly some patients have a remarkable response, like mine. So is there some way that we can discern which of those patients are going to have a really good response to chemotherapy? And, I guess are there other biomarkers? Is there anything else we should be checking to get these patients in for neoadjuvant treatment?
Yes, well, I think the best data to answer that question, Cathy, actually do come from I-SPY, where, as you know, for hormone receptor positive patients, they have to be MammaPrint high risk to be enrolled. And so within that high risk group, they've actually identified different levels of responsiveness to chemotherapy based upon whether they were at the lower end of high risk or the higher end of high risk, which in multiple publications now they have dubbed as high 1 or high 2. And as one looks at the various PCR rates in tumors that are MammaPrint high 1 versus MammaPrint high 2, you can see here that the PCR rate almost doubles when one goes to that higher risk category. They are all chemosensitive, which does indicate that a high risk MammaPrint does predict chemosensitivity, but there's also an increasing level of chemosensitivity that increases with the increasing risk index within MammaPrint. this stratification actually has a cutoff of minus 0.57. As you know, in the high risk range, these are negative numbers going from 0 to -1. So minus 0.57 is the threshold. And so this high risk 2 group into which your patient falls, her index was minus 7.7. It's not surprising that she had a higher, that she had a PCR rate, a PCR result higher than that 6% expected result for the overall group. In fact, from my SPY and the experimental arms, we've seen that these high 2 patients are preferentially sensitive to platinum, immunotherapy, and PARP inhibitors, and may actually exhibit resistance to CDK4/6 inhibitors. I think another question that is raised by this patient is whether or not she would benefit from extended endocrine therapy. And we do have data that was presented at ASCO 2021 regarding the use of MammaPrint in predicting the benefit of extended endocrine therapy. If you recall from B42, the overall benefit of adding letrozole for an additional 5 years was 3.3%. And the question was asked, could we use genomics to identify with more precision who might actually benefit? And so when MammaPrint was applied to the B42 cohort, as was presented by Dr. Rastogi from the NSABP in last year's ASCO, it was really quite surprising to find that MammaPrint could precisely stratify these women into the groups that would clearly benefit, which are the low risk who are not ultra low on the far right, with a disease-free survival benefit of 9.5%, a tripling of what had been seen in the original trial. Whereas those women who were MammaPrint high risk, as in this patient, did not appear to benefit from extended endocrine therapy, nor did the ultra low patients. So it's really only those women who are low risk and endocrine sensitive, but not ultra low, who appear to be those benefiting from extended endocrine therapy. And I know we're running out of time now, so I want to summarize what you've illustrated for us, Dr. Graham, with these tremendous cases, which is the way in which genomic profiling with these assays, the 70-gene MammaPrint assay and the 80-gene BluePrint assay, can inform personalized therapy planning. Because in each of these cases, your decision-making was affected by what you learned from the genomic results. So while we build on the standard pathology, classifying tumors as estrogen receptor positive, HER2 positive or negative, or triple negative, when we apply then the MammaPrint and BluePrint genomic classification, we find many more clinically relevant subsets, each of which has a unique and important clinical implication that is identified by having this genomic information. And we've discussed in this group of hormone positive patients several of these categories that are shown here. We did not have time to go into some of the further stratification we can do in HER2 positive and triple negatives, but because many of your cases were performed on core biopsy, it's important to point out that these results are available preoperatively because we're able to perform them on core biopsy samples with a very rapid turnaround time.
Yeah, and I will just say it has become my practice that all of my patients have some form of genomics to help us make better clinical decisions about how to manage them. And the development of the MammaPrint and BluePrint has really made my life as a surgeon a whole lot easier and has made me feel that I've provided better care for my patients.
Thank you both for that really, really informative presentation. And I really must say I enjoyed the in-depth discussion on the case studies as well. I think it's really fascinating, these extra tools that MammaPrint and BluePrint is giving you in whether it's deciding that maybe women who are struggling with tamoxifen can come off their treatment earlier, or as we saw with our last case study there, who might really respond well to particular types of therapy. So I think that's really interesting. Now, we don't have any time for questions. However, when we send out some information following on from this webinar, you can submit questions that way. And I'm sure both Dr. Graham and Dr. Audeh would be happy if anybody wants to contact them directly. So that's all we have time for on this webinar. Let me thank you again,
Thank
Dr.
you.
Audeh and Dr. Graham, for a brilliant presentation. And I've just been told, if you have any questions, please submit your questions to webinars.events, both of which have S's at the end, at emjreviews.com. So we can take any questions that way if you want to send them in that way. So I also want to thank EMJ for facilitating this. It's been a really great webinar, and to Agendia for their support as well. Finally, I want to thank you, our audience, for taking the time to participate, for everything that you do, both in clinical and in laboratory research as well. Medical advancement is a team sport, so we all have to do it together. If you enjoyed this webinar, do check out our archive and keep an eye out for those that are coming up in the future. The EMG Health, or the EMJ, my apologies, is being rebranded. The EMJ Health website contains all sorts of interesting content, including podcasts on a wide array of medical topics. Until the next time, stay safe, stay well, and most importantly, stay curious. Goodbye for now.
Thank you.
Thank you.